The first step in the clinical assessment of these patients is CT angiography, where we concentrate on the extent of the calcification, whether it is circumferential. So in this multiplanar reform, we are happy to present a live in the box percutaneous pulmonary valve implantation using the Melody valve. It's a 50-year-old male who was diagnosed to have rheumatic severe aortic regurgitation, who underwent a Ross procedure close to 20 years ago using a 20 millimeter pulmonary homograft. There was a brief episode of streptococcal infective endocarditis about 4 years before, which was successfully treated. He's symptomatic for the last 2 years with class 2 dyspnea and palpitations. He was identified to have a narrow pulmonary conduit with regurgitation. Echocardiogram showed significantly elevated RV systolic pressures, conduit gradient of around 75 millimeters of mercury, and there was RV dysfunction. The first step in the clinical assessment of these patients is CT angiography, where we concentrate on the extent of the calcification, whether it is circumferential or not, assessing the stenosis severity, both the length and the diameter, the branch pulmonary arteries, whether they are adequate, coronary arteries, are they too close to the region of conduit stent, and aortic root, whether it can be discharged. So in this multiplanar reformatted images on sagittal, coronal and axial sections, you can see that there is rather a localized calcification around the pulmonary homograph conduit, but on the axial section you can identify that it is rather circumferential, occupying almost 310 degrees of the circumference, with the thickest area of the calcification almost measuring 3.5 millimeters. The branch pulmonary arteries were quite good, they were not obstructed. The coronary arteries in the post-Ross coronary reimplantation are appearing reasonably close to the conduit. This is the right coronary artery and the left coronary artery. And if a conduit stent is placed, it carries a small risk of coronary compression. At the end of the CT, our concerns were there is near circumferential calcification, so we should be prepared for a covered stent in case of a conduit rupture. We should also test for coronary artery occlusion by balloon interrogation. There is a unique challenge. If we implant a covered stent and expand it, there is a possibility that we may compromise the coronaries. But if we serially balloon dilate to check for coronary artery patency, there is a small chance of conduit rupture. So we decided to use rather compliant balloons and check the conduit for coronary compression. So we decided to do a serial balloon testing with left coronary artery and right coronary artery injections. During this procedure, the cardiac output will drop to 0 and the patient may develop a syncope, and so we decided to intubate the patient. The coronary catheter may get displaced during the balloon inflation, so we decided to stabilize the catheter using coronary guide wires. So we decided to take 2 arterial access both for our LCA and RCA. Ultrasound was used for securing vascular access. Heparin was given at 100 units per kilo. Ultrasound was used for securing vascular access. Heparin was given at 100 units per kilo. After placing one catheter in the pulmonary artery and one in the right ventricle, we realized that the peak-to-peak gradient is almost 90 millimeters of mercury. You can appreciate the pulmonary artery trace is rather non-pulsatile, indicating the severity of the stenosis of the conduit. We exchanged the initial thermohydrophilic guide wire to a Lunderquist wire, and this is one of the trick. The catheter may bounce back when you are advancing a stiff Lunderquist wire. So we use a guide catheter, a 6 French guide catheter, which can accommodate simultaneously both a thermo wire as well as a Lunderquist wire, and we place the Lunderquist wire deep inside the left lower lobe area. And once the Lunderquist wire is in a secure position, you can appreciate now the Lunderquist wire entering into the left lower lobe vessel, then the guide catheter is taken out. LMCA was cannulated in the caudal projection and a guide wire was placed to secure it. Similarly, right coronary artery catheter was also cannulated and a 1/4 guide wire was placed to support the two catheters. The initial 6 French pigtail angiography done while we are placing a 5 French marker pigtail along the Lunderquist wire was helping us to calibrate with the marker pigtail and identify that the conduit was measuring almost around 9 to 10 millimeters in its diameter. Serial balloon interrogation was done. Initially, we started with a very small 10 millimeter Mustang balloon. There was no coronary compression seen from the LCA injection and RCA injection. Subsequently, a 12 millimeter Admiral Extreme balloon was used. Again, slowly inflated. At the peak of the inflation, we are checking the left coronary here and the right coronary here. There is no coronary compression. Subsequently, a 12 millimeter Admiral Extreme balloon was used. At 14 millimeter Atlas balloon, again there was no coronary compression in both the left and the right injections, and you can notice with each coronary compression, the amount of blood pressure fall progressively to very low levels, indicating the conduit is completely getting occluded. Is there a chance of rupture with this dilatation? We made a check angiogram after each of the balloon inflations. You can notice that there is a tiny rupture in the proximal right ventricular outflow tract here. You can appreciate this extravasation of the conduit here. But if we carefully analyze the previous sequences, we can understand that the balloon was mostly in the region of conduit and was never in the region of this proximal RVOT. So we realize that this is probably a small guide wire injury or guide wire perforation, which is not of major significance because it is unlikely to enlarge further. Then we proceeded to 16 millimeter ZMED balloon, and this is a 16 millimeter ZMED balloon with a right coronary and left coronary artery injections. There is no coronary compression, and we repeated an angiogram to ensure that there is no perforation of the conduit. Here you can appreciate the previous extravasation has sealed up. The testing went on 18 millimeter. Again, there was no compression of the left and right coronary arteries. And we proceeded to 20 millimeter. There was no compression of the left and right coronary arteries. So there is no major issue for using a 20 millimeter melody. But can we try even a larger 22 millimeter balloon? So we went for a 22 millimeter balloon. Here on 22 millimeter balloon, the cranial projection is not showing any LMCA compression, but the caudal projection is showing a severe LMCA narrowing at this point, indicating that supra-inferiorly the LMCA is getting compressed. So 22 millimeter balloon is not very safe on the LMCA, whereas 20 millimeter may be safer. So we should try to stick onto a 20 millimeter balloon, and we again check the conduit for any tear. There is no conduit tear. The conduit has become reasonably dilated now because of the serial dilatation. The previous small leak that was seen in the proximal RVOT has sealed up. So this is the mounting of the melody over a 20 millimeter ensemble prosthesis. This is the ensemble which is being de-aired progressively, and we are now advancing the balloon out of the ensemble delivery system. So this is the balloon. An 18 millimeter melody valve is taken. The glutaraldehyde solution is removed. It is washed serially in saline. Each wash for about 1 minute and in about 5 bowls, so that all the glutaraldehyde is removed. We check the integrity of the valve. The valve was good, and it is initially crimped on a 2 cc syringe, following which this was mounted on the ensemble delivery system, hand crimped, not using any umbilical tapes. It's crimped with hand, and once it is crimped, we load it back into the ensemble delivery system to see whether we can easily load it. We need to recognize that we have so far not done a pre-stenting. So in order to do the pre-stenting, what we did subsequently was remove the ensemble system again, and we loaded an Andra XL 39 millimeter stent. Initially it was dilated using a 14 French dilator, and once the Andra XL has got a sufficient lumen, we mounted it around the melody valve. So here you appreciate that the stent is being mounted over the melody valve. So this is the stent being crimped on the top of the melody valve, and the melody plus the Andra stent is now getting sheathed by the ensemble delivery system. So the nylon sleeve has fully covered the Andra stent and the melody valve. We do the final de-airing, and now the valve is ready for deployment. We take it through the groin sheath, which has been upsized to 24 French. We slowly advance with a control over the guide wire with one hand, and as soon as it reached the region of the right ventricular outflow tract, there was a brief difficulty in getting the valve getting turned towards the conduit. So a small jerky movement was made in order to promote the movement of the conduit towards the right ventricular outflow tract. We take it through the groin sheath, which has been upsized to 24 French. We slowly advance with a control over the guide wire with one hand. So with this movement, slowly the valve was getting progressively into the conduit. And after the conduit was finally entered by the valve, as you can see in the next few seconds, here it is slowly getting into the conduit. And once we have So with this movement, slowly the valve was getting progressively into the conduit. And after the conduit reached the target, we checked it on the lateral view. So this is the lateral view in which the conduit placement is clearly seen. Then now we remove the outer sleeve. Reached the target. The outer sleeve is slowly getting removed and an angiogram is done from the outer sleeve, indicating that the melody valve with the andra stent is fully exposed into the region of the conduit. The outer sleeve is slowly getting removed and an angiogram is done from the outer sleeve. The inner balloon is inflated initially to around 5 atmospheres. The inner balloon is inflated initially, followed by another check angiogram using the pigtail that has been placed in the conduit. Once the position is found to be correct, the pigtail was withdrawn into the right ventricle and the final dilatation is being done of the outer balloon at 4 atmospheres. Once the entire valve has been and the final dilatation is being done of the outer balloon at 4 atmospheres. Once the entire valve has been deployed, we withdrew the ensemble delivery system by pushing in the Lenderquist guide wire. We can appreciate the ensemble delivery system coming out of the melody valve. And we now check for coronary artery compression. In the caudal projection, there is no LCA compression at all. And in the elevocranial projection, there is a good functioning of the melody valve. Same is seen in the lateral projection as well. Now measured the size of the melody valve. It measured about 18.3 millimeter due to a partial recoil. The hemodynamics showed that the gradient between the right ventricle and the pulmonary artery is close to 20 millimeters of mercury. So we decided to slightly upsize the balloon in order to get a larger melody valve size. So here we are using a 22 millimeter ZMED balloon because there was a recoil following the usage of 20 millimeter balloon to 18.3. So the assumption is that with a 22 millimeter ZMED balloon, we'll get a recoil up to 20 millimeter. So after the 22 millimeter ZMED balloon, again the valve function is quite good. Here the gradient has reduced to 8 millimeters of mercury between the right ventricle and the pulmonary artery. And there is a good diastolic separation between the right ventricle and the pulmonary. Again, the coronaries were checked. The right coronary is having normal flows and the left coronary also is having normal flows without any compression. The hemostasis was achieved with a figure of 8 stitch. Aspirin and clopidogrel were started, and now at a follow-up of 18 months, the patient has a gradient echocardiographically of 20 millimeters of mercury without any pulmonary regurgitation. So what are the messages from this live in box presentation? Conduits can have varying degrees of calcification, severity of stenosis, length. They may have varied relations to the coronary artery and to the aortic root, as well as proximity to the sternum. And conduits may differ in their compliance characteristics, and we have to tailor our strategy depending on the nature of the conduits. Being an alternative to surgery, all anatomical, physiological and safety factors should be followed strictly, and all the hardware should be ready during this procedure. Thank you for your attention.